access to care is a big challenge, particularly for MDS patients. The median age of diagnosis is 72. Many of these patients do face challenges with transportation. I work at the Fred Hutchinson Cancer Research Center that's located in Seattle. We serve as a regional academic center for a large catchment area, including Alaska, Wyoming, Montana, Idaho, and Washington, of course. And we also get patients as far away as Hawaii and in the remote reaches of the Aleutian Islands of Alaska. So it can be very challenging for patients to come to receive their treatments at any center, not even an academic center. And many of these patients really don't have access to IV infusions. So the approval of oral hypermethylating therapy, I think, would be of great benefit to them, because then they don't have to come into a place to receive their treatments. They can receive their treatments locally. Now, their blood counts would still need to be monitored, of course. They can go to their local lab for that. And they can be monitored for other types of symptoms remotely through telehealth visits, for instance. But I do think there's a big challenge for patients, particularly with MDS, because as patients get older, it's common that they don't drive as much and they don't want to face traffic, particularly in Seattle. And so it would be very helpful to have a way to give patients treatment that didn't require them to go to a location to receive that treatment. In regards to wait times to receive hypermethylating therapy, I can really only comment on our own personal experience. We, pre-COVID-19, did have an issue with clinic availability, honestly. It was difficult to get patients scheduled for the IV infusion times. Now, our infusion center has a lot of space availability, but that's not expected to necessarily always be the case. So sometimes it can be difficult to get patients scheduled for their IV infusions. When patients do come for the IV infusions, there's about a 20-minute wait time, and then the IV infusion itself takes about 1 hour.
I think there are several challenges. I think one of them was, the lack of very effective therapies, and I think we are finally having what I refer to as a therapeutic revolution in MDS, with many, I think, good agents being tested, and they are in advanced parts of clinical trials. And we could be in a situation similar to what happened with AML, where you have a long period with no approved therapies, and then you had 8 drugs approved within a period of 2.5 years, and we finally had our first approval with luspatercept after 14 years of no new therapies. And this drug, the oral decitabine, is in front of the FDA currently for consideration of approval. Other agents are in advanced clinical trials. So I think all of this is very good for the patients. It might provide more options. And I think as we get more and more active therapy, we are going to be able to treat more patients. In our real life and effectiveness analysis, what we have found at the population level is that many patients with MDS are not being treated. And I think part of that is related to the lack of very effective therapies, and potentially the lack of oral options for higher risk MDS. So having oral options, having novel therapies, I think is going to be a major impact for many patients with MDS. One of the bigger challenges in MDS compared to acute myeloid leukemia is that the number of actionable mutations that you can target, is somewhat lower in MDS. So in AML, around 40–50% of patients with AML will have an IDH or a FLT3 mutation, which now have approved therapies, oral inhibitors. In MDS, those mutations are somewhat rare. They are less than 5–10% for the IDH, and probably less than 5% for the FLT3 mutations. So they are not often present. So individualizing therapy based on precision medicine or genetic alterations, outside probably of using deletion 5q for lower risk MDS, to use lenalidomide is not as commonly used in MDS. But we are using other ways of individualizing therapy. For example, having ring sideroblast for patients with lower risk MDS could be a way to use luspatercept, especially after ESA failure. another, I think, way to think about other therapies that are being studied. For example, the Tp53 mutation. Now there are agents that are in clinical trials that are going after the Tp53 mutation, which we see in 15 to 20% of AML and MDS patients. So I think we are going more and more in that direction of individualized therapy. But MDS is still lacking or still lagging behind AML for sure in that regard.